So auto PEEP or intrinsic PEEP, incomplete exhalation prior to the initiation of the next breath. There will be progressive air trapping and dynamic hyperinflation. So the curve will, monitor will show like this. Okay, the exhalation flow curve is not returning to the baseline. By that time, the next inspiratory flow happens. So this can lead on to reduced venous return, reduced cardiac output, and potentially cause hypotension, especially if your patient is volume depleted. So this effectively leads to alveolar overdistension. It will lead on to pulmonary barotrauma, ventilator-induced lung injury. The V by Q mismatch increases because the hyperdynamic hyperinflation will compress on the capillaries, further deteriorating V by Q mismatch and leading to hypoxia. So you have to avoid it by giving better expiratory time. It's not the higher minute ventilation. Okay, high minute ventilation may be the culprit. It's not the high tidal volume or high rate. What we require is high expiratory time. That's when we are worried about the IE ratio. Okay. The causes of auto PEEP, it can be high minute ventilation, expiratory flow limitation, as in our case, bronchospasm, inflammation, and remodeling, or even there may be expiratory resistance because of the narrow diameter or kinked endotracheal tube, inspissated secretions, exhalation or PEEP valves, and patient ventilator asynchrony. These are the other causes of auto PEEP. How do you manage auto PEEP? You focus on determining and treating the underlying cause. The bronchodilators, steroids, and antibiotics. Duration of expiration should be prolonged by decreasing the tidal volume, decreasing the respiratory rate, and increasing the inspiratory flow, because your inspiratory time percentage is going to, proportion is going to be reduced. So go for a higher inspiratory flow. So this management may require sedation, pharmacological paralysis, or replacement of the endotracheal tube or ventilator tubing. The role of applied PEEP. How do you, over and above that, you also apply PEEP. How does it help? Applied PEEP hold open the narrowed airways during expiration, improving the expiratory airflow and allowing more complete expiration prior to the onset of next breath. Applied PEEP should be always less than the measured auto PEEP, maybe 50% or 2/3 of the auto PEEP as per different authors.